Good morning, everybody. Welcome to Wednesday and to this week's Insight webinar hosted in collaboration with our partners at APSAD. Great to have you along. And I'd like to begin first by acknowledging the traditional owners of the land on which we are all meeting, the lands upon which we're all gathering today to pay respects to elders past, present, and for those who will be taking up that important mantle in the future. I'd like to also extend that acknowledgement and welcome to any First Nations people who are joining us in the webinar today. So I'm James, I'm one of the clinical educators here with Insight, and I've got the wonderful opportunity today to be facilitating our session with Anthony Bligh, who is the Director of Psychology for Metro North Mental Health, Alcohol and Other Drug Services. So it's really great to have Anthony along. I'll let him introduce a little bit more about himself in a few moments' time. And he's presenting today on the eyes have it, or do they? An introduction to EMDR. So I'd like to just go through a little bit of our housekeeping before we hand over to Anthony. Just basically, if you have any questions or comments to put to Anthony, we're using the chat today as we usually do in these presentations for that purpose. So that's available to you now. And certainly, if you have any technical issues as well, we'll try and resolve those, or there is a telephone number that we'll provide you for Zoom. And also, I just wanted to let you know that this year, again, as we did last year, our final webinar for 2022, which is kind of just around the corner, is going to be a You Can Ask That panel. So I'll remind everybody at the end, but if you have to leave earlier before we get to that point, you'll see a survey that you'll have opportunity to provide feedback. But the very last box on that survey will invite you to provide any questions that you would like to put to an expert panel, because what we will do with those is gather that information over the next couple of weeks. And then on the 16th of November, we'll have a panel of experts in this webinar space at 10 o'clock on a Wednesday, answering as many of those questions that we put to them as possible. So just wanting to flag that with you in case you need to head out early. So without any further ado, I'd like to hand over to you, Anthony. Welcome.
Thank you, James. And it's good to be back doing a Insight webinar again. It's been a long time since I've done this, but I feel like I'm coming home in a lot of ways. For those who don't know me, my background is actually working within the Metro North Alcohol and Drug Service. And really that's where I got the passion and interest for working with trauma, which sort of led into my interest in EMDR as well. One of the things that I often reflect about is my work, particularly in opiate replacement therapy. And I was a psychologist working at the Bligh clinic at Chermside, when I'd often see people who would be coming down on their dose of an opiate replacement therapy. And as they did, I would see the trauma start to arise. What I quickly realized as the psychologist working in that clinic was I had to find a way to help people with trauma to be able to give them a chance to really make it and actually reduce their dose and come off their opiate replacement therapy, or else what I tended to see was they just tended to go back onto a higher dosage again, which led me down this kind of pathway, which, like I said, ended up with me now being very interested in EMDR. Now, trauma and EMDR are very much my clinical passion now, and I use EMDR quite regularly in my work. I will say I'm biased towards EMDR. I'll talk a little bit more about that through my presentation, and where my biases, I guess, sort of come from. But I hold a healthy level of consideration and skepticism, I guess, about the whole process and some of the, shall I say, overdone, maybe putting forwards of EMDR as the cure-all, and I think we need to be careful about the way that it's used in that way. And we also have to use it carefully with the right type of client at the right time as well. And I'll be talking about that in some detail as well. Let's get into it though. So I wanted to start off with a snippet of this TED Talk, which for me, I think might start to give the impression around what I said before, that I'm a little cautious around of EMDR as the magical silver bullet cure-all, and especially the sort of idea of the one-session cure that sometimes can come from this. So I wanted to give you this perspective that is certainly out there in conversations like this.
Hello, my name is Trisha, and I am an adult child of an alcoholic. When I recall my childhood, I can remember that my father loved me very deeply, and he would do anything for our family. However, he suffered from major depression and childhood trauma. He was an immigrant who was financially struggling to support our family, and he was in pursuit of the American dream. He often felt that he was failing, and as a result, he would drink heavily. And when he did, he would be emotionally abusive to my mother and to me. At home, I would feel scared and unsafe. I so desperately wanted my father to be happy again, and I couldn't fix this. And this pain would be so deep within me that I would hide within myself, and I would escape in my books, my academics, and my theater arts in hopes that I would find safety there. My greatest fear in school is if kids really knew what was happening at home, would they still like me? And this would lead me into a never-ending negative thinking loop that would sound a lot like this. There's something wrong with me. I'm not good enough, and I'm not safe. These beliefs would affect me for the rest of my life, even into my adulthood. See, my conclusion was, how can I make meaningful relationships with others if I can't even connect to my whole self? So it was around this time I decided to begin my own therapy sessions. It was in actually my early 20s. My therapist and I began to work on my childhood traumas, and we made great accomplishments together, but I continued to feel shame for what happened in the past. It was around this time I was preparing for my oral examination, which is required of obtaining my master's degree in graduate school. I was experiencing some of the worst anxiety I'd ever felt in my entire life. I couldn't take it anymore. And I asked her, there's got to be another way. And then she recommended a new therapy, EMDR, eye movement desensitization reprocessing. I've never heard of this before, but I was willing to try anything. Well, within 4 EMDR sessions, my anxiety was disappearing. I was experiencing powerful insights that I had never experienced before in previous sessions, and I was healing rapidly. Have you ever seen something so beautiful that it left you speechless? That's how I felt about EMDR. I wanted to know everything about it, where it came from, how it came to exist, and how could I begin to use this in my own therapy sessions with my clients.
All right, so look, feel free, you should find a link in the PDFs that go along with this to watch that full video if you'd like to. But I think that starts to give a view of the maybe miraculous sort of response that you might have heard about with EMDR. And I'll be talking later about why I'm cautious around that. I feel very similarly to the way that she does about EMDR, but there are some realities about it that we also have to consider, especially in the very complex places we work with a lot of the time. Before I go any further, an important disclaimer: I'm not an EMDR trainer, and I won't be training you in how to do EMDR today. I hope you weren't coming along today with the expectation that you'd walk out being able to do it, but I will tell you how to find one, and something about the training process as well. We will be talking about some background stuff quickly. We will be going into what is EMDR therapy, of course, the adaptive information processing model, which is the model behind why EMDR is effective, which I think also applies to a bunch of other trauma therapies too. I'll show you what it looks like in practice with a video. I'll talk about the evidence base. We'll also be covering EMDR in substance use disorder treatment, which I think a number of you may have a particular interest in. I'll discuss a clinical example and then where to find out more, including training. What I won't be covering is how it works. So if you've got questions for me about how anything around this is effective, what's happening at the neuronal level, that kind of stuff, I don't know. And in fact, no one does know exactly how it works. We aren't sure. There are a number of theories about why it works. And there's a link there to a conversation with Dr. Andrew Leeds talking through a few of those. Something like simulating REM processes is one theory. Another one around the working memory hypothesis, where it potentially is eroding someone's ability to think about a trauma, also hold a lot of water. And there's evidence around this and research around this that supports it. But at the end of the day, yeah, we don't actually know how it works, which is one of the main criticisms I see of EMDR, is how would doing this actually affect someone's trauma really? The response I have to those, though, and I'll very briefly cover this and then move along, is we don't know how a lot of things work in the brain. For example, I recently discovered that we don't actually know why paracetamol works. We have theories around it, but we're not entirely sure. And I think this is one of the things that is so amazing about our brains is at best we have theories about why things happen, but we're not ever really completely sure about a bunch of things. Maybe we will one day. Wanted to come back to an important consideration of the way I see the issue with trauma. So a lot of times we get caught up on what happened. And I see a lot of debate and invalidation for people who've been through a trauma that wasn't as bad as someone else's trauma. I work with people who will say to me, but this isn't as bad as someone who's been to war, for example, or someone who's had a major loss in their life, or other sort of near-death experiences. So why am I so traumatized by this? And for me, it's not about what happened. It's about the effect that has on the person, and that's individual. Two people can have exactly the same traumatic thing happen and have completely different outcomes from that. And part of it is around this, the frozen residue of energy that had not been resolved or discharged. And I'll go into why I guess I think that happens in terms of theories a little bit later as well. But the concept here that it remains trapped and it can wreak havoc on our bodies and spirits is an important one. That I think when someone remains in that hypervigilant fight or flight place, that PTSD can really be like. It's one of the main symptoms of PTSD. From my basic physical knowledge, I think that actually does some damage to our physical bodies as well. And there's some research to support that. There's some local research to support that as well that has been done in Brisbane. Looking into the neuronal level as well, though, we can see that PTSD has an effect on the brain. Don't ask me to go into the explanation of why these things are relevant. My knowledge of neuroscience is fairly sort of basic, but we do see in studies that look at veterans who have PTSD versus veterans who don't, that there are changes in the brain that are observable. And I think that's just one example study from 2017 that shows that. There are a number of evidence-based therapies for PTSD, and I think it's important to consider that EMDR is just one of these. Exposure therapy and cognitive processing therapy, or CBT, which work basically, I see CBT as the cognitive component added to exposure therapy, have the most evidence. There's no doubt about that. And really the idea around that is you are desensitizing someone to their trauma by continually having them think about and even find ways to go and remind themselves about the trauma in and out of session, alongside challenging the meaning made from trauma. Plenty of evidence for CBT, and I'm not discounting the fact that CBT with a trauma focus definitely works. The reality is, though, that there is now plenty of evidence to say that EMDR is as effective as CBT with a trauma focus. So we are no longer in a place of wondering if EMDR is an evidence-based therapy for PTSD. We have the evidence around that. It is important to note, though, any trauma therapy, in my view, requires the person to be able to tolerate memory of trauma while remaining present with the therapist or even their environment being safe. And the concept of trauma therapies across the board being effective is about, I was not safe then, but I am safe now with my therapist when I go home, these types of things. And so it is more important for me that we get that right. The person can tolerate this in session with me rather than getting too caught up on actually even what we're using. I want to come back to an important concept around this that goes for in and out of the therapy room. You've probably all heard of, if not learnt about, Maslow's hierarchy of needs. We probably all learnt about this really early on in our training. I certainly did. Probably, first year was where I learnt about this. And unfortunately, after learning it, I've noticed that people tend to forget about the importance of this. When someone doesn't feel safe, and that is the issue for the person in their environment, everything above it is less important. So for the fact that, particularly in the esteem box, self-esteem, confidence, achievement, respect of others, respect by others, is well above safety. I think we often see people who are behaving in ways that we would say are counterproductive for them. If they're not feeling safe, that's going to be front and center for them. Those higher level things are less important. If we can't establish safety for the person, when we're getting into meaning making from trauma, etc., and trying to treat that, we're not going to get very far. And what this brings me home to is if I do a great EMDR session with someone or CBT trauma focused with someone, and I get them through that trauma and they're doing well in session, if I send them home to a place that is about domestic violence, ongoing alcohol and drug use, maybe problems with neighbors next door even that are hassling them, reminders and triggers of their trauma on a daily basis, I'm not going to get very far in my trauma therapy. So I just like to remind people about that. Establish safety for the person first before you even think about actually treating their trauma. That's probably most important. Anyway, enough of the background stuff. Let's get into EMDR. So EMDR is all about the concept of co-consciousness. We want the person to be thinking about traumatic material while also focusing on some form of bilateral stimulation. These can be lateral eye movements, where you're actually asking the person to follow your fingers with their eyes, hand tapping or hand buzzing, or audio stimulation, so sort of left, right clicks or buzzes if people have sort of headphones, that kind of stuff. After you do that for a while, there is a free association process where you will say to the person, what is coming up for you now? and then you keep following that pathway. So one of the major distinctions for EMDR and CBT with a trauma focus is you will let the person go where they want to go, rather than continually bringing them back to that trauma that they were thinking about. And there are some interesting paths you can go down there, because one thing will lead to another thing, will lead to another thing, will lead to another thing. And you tend to find, in my experience, that that pathway sometimes doesn't make immediate sense, but later on, sometimes there's links between memories, sensations, feelings, etc., that become very interesting ways of better understanding that person and helping them through their trauma. You do periodically come back to the trauma you're working on, though, and you're not done with that until the person can say they have a 0 SUDS. SUDS is the subjective units of distress scale, basically a 0 to 10 or a 0 to 100, if you like, rating of how distressed the person is feeling right then and there. You go until it's 0, absolutely calm when thinking about that traumatic memory. And that can happen in a single session. I've had plenty of people I've worked with where it's been several sessions before I've got to that. So once again, I recommend caution on the idea that it is always a single session. It's definitely not in my experience. Like all trauma-focused therapies, though, we are teaching people behavioral coping skills first. Before going near this, they have to be able to be safe. They have to be able to think about the trauma without becoming overwhelmed as well, so that we can actually go through this sort of process without overwhelming them and having them re-traumatized by the actual therapy. Just talking about the phases of EMDR therapy. The most common understanding of EMDR is it's this kind of waving your fingers back and forward. That is just one stage of the therapy. There's obviously history taking first off, the preparation phase, which can be years in the making of getting the person to the point where, for me, my indicator that someone is ready to move into the assessment phase is they can get triggered into their trauma outside of session and come back to me in the next session and say that they were okay. They weren't great, it wasn't wonderful, but they could come back and say, oh, I've taught them something, or they already knew something that they were able to use to get themselves through it. And that could be the use of just general CBT, acceptance and commitment therapy work, mindfulness, grounding techniques, sensory approaches, whatever. I was able to get through it. The reality of all of this is any trauma therapy, in my view, is going to make things worse before it's going to make things better. And if the person cannot handle worse right now, in my view, you do not want to be going in and starting any trauma therapy for that person. I want to see that they can handle worse effectively. And it's, like I said, not going to be great, but they can get themselves through it. The assessment phase is different to history taking, because in the assessment phase, I'm working out what specific memories I'm going to be using to target my EMDR around. And I'm looking across 3 areas there. The past, which is by far and away the majority of the memories, all the things that have happened that are triggering the person into the issue that we're working on, present triggers, and then you actually set up some ideas around future templates. So likely triggers in the future that we can help people to cope with EMDR. Finally, then you get to your finger waving and your desensitization phase with the processing of the memory. The installation phase is where you're actually working on a positive belief. It's like the silver lining that comes from the experience of trauma. What's the positive belief about you that comes from you getting through this? That can be, I survived, I'm okay now, I actually was good enough the whole time, these types of things. And that's a really important one for me, because that is about new meaning making through what happened. The body is not left out, though. For anyone who's read The Body Keeps the Score by Bessel van der Kolk and other sort of body-based therapists, a lot of trauma is contained within the body, and EMDR will process any sort of sensations, difficult sort of feelings that are still contained within the body until that is clear as well. and then we close things down. It's a lot more than just this for processing trauma. I've mentioned a bit about preparation already, but the only thing to add here is that EMDR actually also involves a number of techniques to enhance positive feeling. So the development of safe places and other positive resources are part of the EMDR training, and you actually use some of the bilateral stimulation to enhance the feeling of safety or positive resources for the person. And that's a really positive aspect of the therapy that often isn't talked about that much. The adaptive information processing model, as I mentioned, is one of the models behind why EMDR is effective. And I think this is actually something that comes back to and is common to, well, a range of therapies, not just trauma therapies. And let me talk this out a little bit. The idea is our systems are designed to promote health and well-being. Your body, your brain wants you to be healthier and happier. And if you've ever worked with someone who has been through trauma, and I'm sure you all have, because we know about the prevalence of trauma within the alcohol and drug world. What you might have heard them talk about is flashbacks, and these things keep popping up in my mind, and I don't want them to, and I try and avoid it. In my view, that is your brain trying to heal itself. That is your brain trying to desensitize you to your trauma, and it is throwing these things up to you to try to get you to work it out. The idea is that what is supposed to happen there is that disturbing memories are moved to some sort of adaptive resolution. We make some sense of it. And I think dreaming is part of this as well, making sense of what happened in a way that helps us to kind of move forward. And what ideally happens is that disturbing memory that was so difficult becomes now something that helps us to cope the next time we are faced with this. I think this is how we have developed as humans to be adaptive to our challenging environments. And let me give you an example that's personal to me. When I was at school, I found public speaking really difficult. I was extensively teased, and I'd say even bullied for some of the challenges I had in public speaking. What I did around that was avoid public speaking for a lot of my life. Now in my job, I can't avoid public speaking. It's a really important thing that I need to do. What I found I was able to do was through challenging myself to go through some difficult experiences of public speaking, and lecturing at university was the place that I did this. I was able to get to the point where these challenging circumstances that I survived and got through and got some positive feedback around started to, as I did them more and more, became positive memories of for me of why I actually enjoy public speaking. I was able to use that effectively to confront those traumatic memories, if you like, of public speaking in high school. And to actually see that this was maybe a dysfunctionally stored memory system for me, that I'm not good at this, to something where I can now go in and do something like this and genuinely enjoy what I do. And I think that's a really great thing for me personally to experience, but also it teaches me a lot about the way humans work and how we can overcome our challenges. If you think for yourself about the sort of things that have been challenging in the past that you have overcome, you might have a similar kind of perspective on this. And maybe now there's more positive experiences of you actually overcoming that challenge, doing things a different way, that now fills you with confidence that I can do this. The idea is, through our life experience, we may have a network of these functional memories that have taught us how to manage challenging situations, and that we learn how to do things and how to manage challenges through prior experience. But what happens when the situation we are faced with is overwhelming? When we actually have a near-death experience, when something about the meaning made here is too much for us to cope with, it's too much for us to deal with. The flashback is now so triggering that I can't deal with it. What seems to happen is we avoid thinking about that. We try to switch it off. A lot of our clients will use drugs and alcohol to do exactly this. And what seems to happen is we never get to the resolution. We never make sense of it. We never kind of review it with kind of up-to-date thinking. And what seems to happen for the person is every time it gets triggered, it's the same emotional state as the time of the trauma. The past is the present, is the way that this gets talked about in the trauma world. The person is now right there, it's happening again, and I'm experiencing my trauma again, and it's too awful, and I need to do something to stop this happening. We just never make that resolution. You'll often hear about people who will have nightmares, recurrent nightmares around their trauma, who wake up not ever resolving that nightmare either. So I think it just stays there and we never get past it. The theory is that EMDR works, and I will say, like I said before, that I think this is true for other trauma therapies too, to give us some access to our adaptive memory network, like reviewing the traumatic material with a different perspective. It's like we take all the things we've learned in our life that make us adaptive humans, and we apply it to that situation that happened in the past. I'll sometimes say to my clients, it's like we get in a time machine. We go back with you to the time that the trauma had just happened. We find that kid, we sit down with them, and we talk to them as a caring, compassionate adult that oftentimes my clients are so good at doing for everyone else and so good at doing for other kids, but just have not been able to apply it to their own traumatic material. And I say it's like we go back and we have that conversation with that kid and we give them a different perspective. And if we do that right, and we can sit them through it and they can cope with it as well, that it isn't overwhelming in the session because of all the other things I taught you already, now we can process this memory, we can get you through. And the great thing is that memory that was traumatic now becomes part of your functional memory network. This is now a memory that you can draw upon as a time that you survived, that you overcame adversity, that you got through it, that you actually were good enough, etc., etc., etc. And I see the person then become far more calm, adaptive, and doesn't sort of have those flashbacks and difficulties anymore popping up around that memory. Which has us pause and think about the fact that for EMDR, the evidence is all about PTSD, but are there other psychopathologies that are driven by a set of dysfunctional memories, like depression? Does the person have a set of memories about their inability to do things, their lack of motivation, their feeling of hopelessness? Anxiety. Does this person have a set of memories associated with the sense that bad things happen and bad things are going to happen in the future? Borderline personality, that we often know is so strongly associated with past trauma, a sense of abandonment, neglect, and a sense of worthlessness, and substance use disorders as well. So that's just a thought experiment for you. This is a really great explanation, and I love the simplicity with which this one comes across for an understanding that hopefully a client could sort of take on board and say, yes, I can see myself in this. The idea is before EMDR memory, we've got a high emotional charge. They've got the SUD scale there of 0 to 10, and the trauma feels like it's happening now, even though it was years ago. And after EMDR therapy, the image is a bit less colorful. It's a bit more blurry. And it's like, you can see, it's like this person's watching it on a TV screen versus it being right there front and center. It happened in the past, and it's got that 0 level of emotional charge. That's what we're trying to achieve. And the words, it's just a memory now. It's kind of a saying in the EMDR community that we've got there then. So what does it look like? Enough of me chatting for a little bit. I'm going to show you a demonstration of what it actually looks like. I've watched this video and it really is like this. This is exactly kind of how it goes a lot of the time. We don't see much emotionality coming out here. Sometimes people will get quite emotional through processing, and that is just part of it. But a lot of it looks as boring. I still think it's fascinating. A lot of it looks as boring as this is. So I'm just going to show you 5 minutes of this. So come with me now on this journey.
It's about. So hope you enjoy. Okay, so today we're going to be processing that memory of your parents yelling at you when you were a young girl, right?
Mm-hmm.
Okay, so would you be able to tell me the image that represents the worst part of that memory?
I think the thing that stands out the most is the image of me in my room crying alone.
Mm-hmm. When you hold that image of you crying alone in your room, are there any negative beliefs about yourself that feel at all true right now that go along with that image?
I think what comes to mind is like I'm bad, or I'm a bad daughter.
Okay.
I'm a bad kid.
Okay. Is there a belief that you would prefer to feel about yourself that would go along with that image?
I guess I would like to believe that I'm good. I'm a good daughter. I'm a good person.
Okay. As you hold that image in your mind of you alone crying in your room and you say the words to yourself, I'm good, I'm a good daughter, how true does that feel on a gut level on a scale from 1 completely false to 7 completely true?
Probably like a 1.
Completely false.
No, yeah, not too true.
Okay. As you hold that image in mind and you say the words to yourself, I'm a bad daughter, what feeling comes up right now?
Like shame, guilt, sadness.
Where do you feel that in your body?
In my stomach.
And right now, how strong is that feeling from 0 to 10?
I would have to say like an 8. Pretty strong.
Okay. Can I ask you to take the image, that negative belief of I'm not good, I'm a bad daughter, and those feelings of shame and guilt, and can you go with it?
Let's do it.
Right? Hook him up.
I just had this memory of my mom being outside my door, like calling my name.
Go with it. Hook him up.
I remember I thought she was, coming back to yell at me some more, but I think she was more concerned that I was all alone in my room, because even though they yelled at me, they didn't want me to be upset and alone.
Okay, go with it. Okay, Mom.
I guess maybe I feel, I don't know, a little better, like just that when she came to, talk to me or was calling my name, it made me think maybe I wasn't like the worst daughter ever, like, because she was still a little concerned about me, even though she was mad at me.
Okay. Would you be able to go back to that original image for me? Can you get that back up?
Sure.
Do you notice any disturbance?
Yeah, I still feel like a pit in my stomach, kind of.
Okay. 0 to 10. How strong is it?
Maybe like a 6.
Okay. Go with that 6.
Okay. Can I close my eyes?
You can. Okay. What came up?
I was thinking about how, like, even though my mom came to my room, I felt like I couldn't talk to her because I was so embarrassed and like ashamed of like what I did. I just couldn't think of facing her.
Okay, go with it.
So that'll do for that. Look, I'll just really briefly comment on it to say that I hope what you could see there was some of what I was talking about before, that she's reviewing this material and getting some different perspectives, some realizations around things. She's thinking about it in a really different way from her mum's perspective too. And that is changing her meaning about herself in that situation. That's often the experience of EMDR, is as you're sort of working through, the person is kind of making sense of it in a really different way, which is resolving those the distress associated with it, while also processing the body sensation she's got, like the pit in her stomach. The buzzers she was holding as well, they're just like the way your mobile phone will buzz, just one in one hand, one in the other, and it just alternates in terms of the buzzing. I do like the fact that people can close their eyes at that time, but if you've got someone who is likely to be a little dissociative, that can be a problem because you can lose them at that point too. But they can be really effective for people who want to do that. Anyway, I wanted to just give you that really brief view of what it actually looks like, and feel free to watch that whole video as well, which you should have in the links in your PDF as well when it gets sent out. So, is EMDR evidence-based? Well, I've mentioned a couple of things about this, but before I actually go to a bit more information on this, I want to talk about the elephant in the room. When it comes to the evidence base on any therapy for trauma or PTSD, we have an issue. The way that we like to understand whether therapies are effective or anything is effective is we like to isolate that condition to just that condition, and then we apply a therapy or not, and we see whether it's been effective. The really difficult thing with trauma and PTSD is, as a disorder, it very rarely presents as just itself. You will often not see someone who just has an issue with trauma. Oftentimes there will be depression, often, and anxiety. Can be substance use disorder as well. It can be personality disorders as well. It can be psychotic disorders as well. So the opportunity to have it as a unique disorder in itself is really tough. The other thing is that when you try to research trauma and we apply the evidence-based approach, there's all the preparation stuff to think about, and that's going to be different for everyone you work with. Dropout rates are really high because as you're applying this, sometimes people are overwhelmed. It's a tricky thing to really explore this in a pure scientific sense and control all the possible variables. But it has been researched, and even though this is now getting a little old, I tend to refer to the Cochrane review because it is probably the most rigorous in terms of the reviews done around this. There were 16 randomized controlled trials for EMDR and 49 for treatment-focused CBT. They found that both of those were equally effective for chronic PTSD and superior to non-trauma-focused CBT, so just general CBT, other therapies, and sort of control groups as well. But the quality of the evidence was low across the board due to some of the things I talked about, variations in protocols and biases as well. And it also mentioned that exposure therapy increases dropout rates as well. There is a growing evidence base. It continues to grow, mostly for PTSD. But at the end of the day, the World Health Organization has endorsed it. Our Australian PTSD treatment guidelines do, as well as the APS evidence-based practice guidelines. So in terms of, is it evidence-based? Like I said early on, that debate is done. Yes, it is. We know it absolutely is. I think now it's just growing evidence base around other things as well that it might be useful for, like depression, anxiety, other things. Another important consideration in this, because I mentioned about how PTSD changes the brain. So what does EMDR do to the brain? There have been some studies on this as well that will show changes in things like the primary visual cortex, the superior parietal lobe, and fusiform and lingual cortex. Once again, don't ask me to comment on the neuroscience behind this and what that all means, but we are actually now seeing brain studies that show that EMDR is doing something. I don't know if that's also replicated when you do CBT with a trauma focus. It may very well, but I have seen some studies that actually see qualitatively different outcomes for people who do those therapies, all positive outcomes, but it's almost like they're working in a different way. Where the debate is now focusing, like I said, it's no longer a debate about whether EMDR works, it's whether it's actually distinct from other therapies, in particular trauma-focused CBT. And there is still quite an active debate in the literature about whether it's actually different. And what I will see, distressingly I will say, is salvos being fired one way or the other between the CBT folks and the EMDR folks, doing different meta-analyses, etc., to prove that their therapy is the best one. And I'll see a lot of biases in the way those are done on both sides. So people will cherry pick the sort of studies that show that their therapy is more effective on both ways. And I'm really distressed about that for this reason. We know far and away that the thing that makes the difference with any treatment, not just for trauma, is less about which therapy you choose. As long as it has an evidence base, which therapy you choose is actually significantly less important than the therapeutic relationship and things that happen outside of therapy that we have no control over. Which option you choose is actually really quite tiny in the outcome, in the variation of outcome. So my sense is, shouldn't we be choosing which therapy we go with based on the individual needs of our client? What's going to fit best for them? And that is why I'm biased towards EMDR, because I feel like it is a gentler, more client-focused approach to the treatment of trauma than CBT with a trauma focus. And I don't take anything away from people who prefer CBT, who use CBT, who want to go down that line and find it effective. Go right ahead. For me, I prefer the EMDR approach. Let me tell you a couple of reasons why. The first is there's much less of a focus on exposure. So firstly, it only happens in session. There's no homework. CBT with a trauma focus, you will be doing your exposure in session, but you'll record the session and you have to listen to it over and over and over between sessions and come back and think about the trauma, think about the trauma, think about the trauma. You're only doing that in session with the EMDR. And so the no homework factor is a whole other positive as well, but that's one of those as well, that we're just not consistently focusing on exposure to get that outcome that we want. My clients don't actually have to tell me what the trauma is through their processing. I've processed whole traumatic memories without the person actually telling me a single thing about what the trauma actually was. And I think that's a wonderful thing for me and my clients. They don't have to do that. And possibly the most positive thing is the clients get to follow their own path. I mentioned that you will ask the person, and you saw it in the video, what just came up for you, what are you noticing? And then you follow that path through your processing. I find that very client-centered in the approach that I'm taking there. Anyway, like I said, I'm a bit biased, but that's why I prefer EMDR. There are some times to not use EMDR that are important to note. If the person has to provide evidence in a legal case, sometimes EMDR can be seen to affect the actual specifics of the memory. I showed you that diagram before of the really bright image versus the less clear image, and that sort of idea of them watching on a TV screen. So the idea that the memory can change, I think, is reality. So I always check with people that they're not going to be taking things to a legal case, and we find other ways around that if necessary. Pregnancy or medical history that might present risks if the person can't regulate their emotions or is unstable, or if they're highly dissociative as well. I did want to mention about EMDR and substance use disorder as well. There's an interesting premise here without the evidence to support it, unfortunately, just yet, but I think we're getting there. The idea is that perhaps some memories around, I left one substance abuse in my slides. I needed to change that. Sorry to everyone who, I know that's the wrong term to use. Euphoric memory associated with substance use disorder, that should say, being a dysfunctional memory. And I worked with a lot of people in my drug and alcohol work who would talk about that first time they used a drug or even alcohol as this wonderful memory they had, and they're trying to get back there. They're always trying to get back to that time that was so wonderful for them. The idea is that perhaps this is a dysfunctional memory of its own, and we could process that with EMDR through our adaptive memory networks to really look back on that and say, well, hang on a sec, is that reality? And I think there's been some sort of success with that. Cravings can also be targeted and desensitized effectively. And that's part of the sort of surfing the urge technique that we know about in drug and alcohol work, among others. So EMDR potentially could be used to also manage cravings. And that sort of euphoric use memory and cravings, if we could process down to have no sort of emotional component to them, perhaps that could have a positive outcome. Like I've said, there's a lack of research around this. There's not none, but there's just not enough. One of the big problems there is there's different people doing this different ways with different protocols. We kind of need one consistent way of approaching it that actually we research and have a look at. There is, though, a lot more evidence to say that PTSD-focused treatment alongside alcohol and other drug treatment is showing effectiveness for EMDR rather than that specific targeting of substance use disorder. Let me show you some results on this. It's not the most what should I say, well-controlled study, I guess, here, partly because it looks like pre-treatment there were some significant differences between the groups here. But with 40 people receiving substance use disorder in northern Italy from a study from 2018, they split that into two groups, 20 receiving treatment as usual, 20 with treatment as usual, plus EMDR with that PTSD focus. We did see better outcomes for people who got the EMDR as well on the IESR, the impact of events scale, which is really targeting the PTSD symptoms. There was a bit of a reduction when it came to the SCL90, but sort of less evident, if you like, although very little change for the treatment as usual there. But like I said, if you look at the impact of event scale pre-treatment, there was quite a difference there. So we need more data around this, but there is, like I said, a growing evidence base around that as well. So my recommendation based on this would be our work in substance use disorder treatment should be how we treat trauma and how we treat that underlying trauma in the first instance before we start getting too involved in whether we're using it to treat substance use disorder directly just yet. I'd now like to give you an example of my use of EMDR, which sort of presented me with some cautions. And I promise you I'll keep this brief and then I will be going to actually answer some of your questions. I realize I'm getting close to time now. So I worked with a woman who had a history of ice use and cannabis use, a number of stressors in her life that were really causing her a lot of dramas. She had a bunch of traumas in her life as well. Abandonment as a child from her dad, There was a sexual assault later in her life, and she actually found that cannabis was a great way for her to cope with the trauma from that. She later found that ice use was helping her to manage her anxiety and her sense of sort of, I guess, hypervigilance. So I actually targeted her memory of abandonment, and I felt like she was very stable in her alcohol and drug work because she wasn't actually using alcohol or drugs. And I felt like we'd done really great work with her in the alcohol and drug field, and she was ready for EMDR. I had just done my EMDR training, and I was full of the miraculous therapy that this was, and I was going to go out there and heal the world. And so I focused in on this memory of abandonment for her. In one session, I got her down to a SUDS of 0, and we completed the memory, and I was congratulating myself as being the world's greatest therapist, and ready to receive my award. The really tricky part was, and I did go and get some supervision, and they were a bit horrified and were telling me I hadn't stabilized her well enough yet, and I was really confused about that at the time. But she didn't come back. At least initially, she didn't come to her next session. When I finally got her back 3 months later, she had relapsed quite severely. She had really had all of her other traumatic memories just get kind of shook up. And that had sent her down a bit of a spiral. By all reports, she's doing really well now. She did come back to do a lot of work, and she has, like I said, by all reports, really got there. So she's okay now. And the positive thing was that memory that we processed was still a 0 for her, no distress at all, and that had held. But what I realized was, what I said before around, can this person tolerate being triggered? Can they deal with things getting worse before they get better? Was very far from where she was. She was not safe in her environment as well. There was still a bunch of issues for her at home. And so we need to make sure people are capable of dealing with the distress that comes up from trauma before we go in and do this kind of work with people, is what this taught me. Our work in substance use disorder treatment, in my view, needs to be about how we stabilize someone to be safe, to be able to cope with triggers as they come up. Once they're there, then we start thinking about this type of thing. And that can take years. I did say I'd tell you a bit about where to get training. Here's some links to the training courses. You need to know that EMDR training, just basic training, is 2 3-day courses with 5 hours of supervision after each and some time using the therapy. It's not a quick training course to do if you want to do it properly. There are some trainers out there who'll do a fast track. My advice to you is do it properly. Get the full training. Learn everything that goes into this. And I'll also pre-warn you that EMDR training involves you getting EMDR. Part of the training is you're receiving it from others and you practice on each other. So the positive around that is you'll get some therapy from doing EMDR training. The downside is you'll get some therapy from doing EMDR training, and that can be confronting. But I highly recommend it. Even if you're a little interested in this, go and give that a try, or at least look into it. If you want to learn more, here's some places to learn more. The International EMDR Institute, EMDR is the Australian Association, and the Francine Shapiro Library has a bunch of research around it too. So with not a lot of time left for questions, and I will hang around a bit for questions. So sorry to everyone who might have to leave us. But like I said, I will hang around for questions for a little while. That's it in terms of the presentation.
Great. Thank you, Anthony. And thanks for being generous to stay around for a little while, because we do have some questions have come through. For anyone who has to leave, I'll say a thank you. So that you can leave at any point. It was great to have you along. Just a reminder about the survey when you exit, and feel free to look at that last question to add anything to what's going to be our panel discussion in November. And next week, and I'm just putting all this up front now, we will get to the questions, we have Victoria Kostanets Nov from the National Centre for Education and Training on Addictions, and Jack Nagle, who'll be speaking about lived experience in the AOD workforce. So over to you, Anthony, with some questions. Look, thank you for explaining that. Certainly, I always find it really useful that to speak to somebody or have someone speak about when they're a practitioner in this and when they're using it and they have that kind of clinical knowledge, because it's a parallel, probably not exactly the same, but to a bit like, say, psychedelic assisted therapy at the moment, or MDMA assisted therapy. It sometimes feels like it's all about the drug, or in this case, it's the finger movements. But when you actually talk to somebody, there's a whole protocol and regime around supporting that. That it's not just this kind of one element that seems to get, plucked out and representative then of what is the treatment. So bearing that in mind, a couple of questions here. EMDR, is it considered useful for complex trauma or trauma type 2, whichever way, whichever language that you're comfortable talking about that?
Yes, 100%. To tell you the truth, I'm yet to see too many people who don't have complex trauma in my work. It just tends to be what we see all the time. So 100% yes, and there are some papers that specifically focus on the use for it with complex trauma. But I'll answer that with a simple yes, 100% yes.
Great. And because we've got a few questions coming through, I hope we can get to all of them. We may not be able to get any that have been added in the last few minutes. And if people need to leave, that's all fine. So a couple of statements here around emotional freedom techniques and therapies, those self-help type therapies. I'm not sure if you're familiar with them at all, but any kind of suggestions in relation to EMDR versus a technique like clinical emotional freedom techniques. I would just comment there that I really like that you emphasized that in the world of what we do, it's not a one-horse race, and you might have your preferences, but it really does come down to the fact that it's got to be what works for the client, and we should never be, trampling on other therapies in any way or holding one up as being sort of like the superior, because it isn't a one-horse race. So thanks for really kind of emphasizing that point. We can have our preferences, but it's a big world out there, and lots of things are helpful and useful.
Agreed, James, and yeah, it's about fitting it to your client. It's about sitting down with someone and saying what's going to work for you. It's being formulation driven about the way you do things. So I'm not completely familiar with those therapies that were mentioned, but what I can say is generally it sounds like those types of therapies are the things you'd be doing in the preparation phase. Anything that's going to work for that person to get them to the point where they are stabilized enough to be able to manage sitting with trauma is what you want to do. And I tend to find that EMDR works alongside anything like that really nicely, and tends to just enhance what you're doing with those types of therapies. There's a lot of people who will, I guess, find something positive in a therapy like that and do a bit of bilateral stimulation to enhance that positive outcome that comes from that. So I mentioned that there's a lot that actually goes into preparation with EMDR around safe places, etc. And you'll use bilateral stimulation to enhance that. Similar again with any sort of positive outcome from another therapy, it seems that by adding in some bilateral stimulation, it can reinforce the positive aspect around that. That's not researched enough, that sort of aspect of it, but that seems to be the way that it can be effective. So I'd just say it would nicely dovetail, I think, with those types of approaches.
Definitely. Does a client have to have a specific trauma event that they're focusing on, so as to be able to benefit from EMDR?
That's a really good question, and I would say it probably comes back more to why don't they? So let me explain what I mean by that. If someone is so highly dissociative that they can't remember what happened, but they've just got a feeling like maybe something did, or they've been told by someone else that they might, I would tread a little cautiously. You might open up a can of worms for yourself to kind of race in there. But what I work with is people who'll say, I have 1,000 examples of that trauma, and I cannot remember a specific example of that time. That example I showed you of parents yelling at a kid, with some of my clients, that was daily, if not hourly. So how do you come up with that time? There are a bunch of ways I try, but I will have sometimes someone, and I'll say, just come up with a representative memory of what it probably looked like, what it probably felt like. That works pretty well. You can target a body sensation, you can target a belief. There's lots of different ways you can actually focus your EMDR. So not necessarily, but ask yourself the formulaic question as to why it is they can't give you a memory. And as long as that isn't something where you're likely to open up a can of worms for yourself, yes, it could still work very well.
Definitely. This one you may have mentioned in relation to achieving a SUDS of 0, subjective unit of distress score. So what are there any kind of coping mechanisms for dealing with the after effects of EMDR? However you read that question, because I guess it's open for a lot of different ways of thinking about that. But my sense is around, is there I guess that maybe some of it's around safety.
Okay, yeah, I'm just wondering, what you mean by after effects.
Yeah,
so I get the way I'd interpret that is maybe that's that it gets worse before it gets better stuff. And here's what I do with that. I will say to all of my clients, especially the first time we're doing processing, to be very aware that the next few days could be tricky for you. You might want to have a nice quiet weekend. I tend to see people on Fridays. You might want to think about having some trusted people around you. You might want to plan any big social events over the next couple of days that potentially are triggering, and you might have some nightmares and things like that. Note what happens, because this is an indicator for me that we've gone too deep too quickly for you. We need to do some more stabilization work, etc. And really preparing someone to actually use all those things we did in the preparation phase to apply those again. Hopefully by then we've learnt the tricks for this person. They really love these types of ways to stabilize themselves, and it's reminding the person how to use those. And you might need to use those more over the coming days.
Yeah, no, thank you very much for that considered answer. And just a reminder again, we'll probably go till about 10 past, just out of respect for you, Anthony, and also for those who are here. So any of the questions that have come in since we started question time, we won't be able to get to. I do apologize, but you've given some good links there, and they're available in the PDF. Just a couple of, I don't know if they're quick ones. Are there a specific number of times you repeat the finger movements, like that demonstration we saw?
Look, I'll answer that really quickly by saying not necessarily. In your initial training, you'll be taught that, because they like to keep it simple. But no, look, the way I work is I get a lot of guidance and feedback from the client I'm working with for how many to do. And I will say, if that person is at a higher level of distress or overwhelm, I'll do less or slower movements. If the person is in a place where they are really processing something, I can see that they're getting somewhere, I'll keep going to sort of get them through it. So it's a little bit of a working out where your client's at and sort of feeding into that. But that comes with experience and training.
And thank you for showing that video. That was really helpful. And you can really see, again, like any therapy, how much you need to socialize and provide a rationale to a person so that they understand what's going on and engaging in that process. And as the client was showing quite well. Any age considerations in terms of the research or evidence base?
Look, there's research across the entire age span, and I will say, although I'm very skeptical about this use with babies using EMDR, which I'm like, I wouldn't go there. But certainly young children, and the sort of finger puppets you can use to sort of get sort of a focus on what you're doing. There's lots of research around that. Not an area I work with, but plenty of research knowledge, and we actually have some of our KIMS clinicians who use this quite regularly in their work with child and youth, and people who use it in the older person's teams as well. So across the age span, there's research supporting it.
Thank you. Probably more of a comment here, bit of a question. If highly dissociated, as you mentioned, that's a bit of a consideration at the point. Same with any type of therapy, really, particularly trauma-focused therapy. Would you start with DBT? And again, there's probably no right or wrong answer to that. Yes, if you were competent in that and the client was from an informed consent point of view, hopefully I'm not answering the question for you.
You are. It's exactly right, James. Yes. Yes, I would consider DBT if it's going to fit for them. If they're willing to, attend that. Of course, DBT is a great frontline therapy for dissociation. I use something called internal family systems therapy. That's my go-to. There are a range of different approaches to working with dissociation. The greatest difficulty is there is zero solid evidence base for an approach to dissociation work, because as mental health professionals, we still don't yet agree that it exists. So we have a big problem there, especially with dissociative identity disorder, around actually developing an evidence base. We have to come back to actually just acknowledging it's a thing before we can do that. But yes, DBT is a wonderful approach to helping someone stabilize.
Absolutely. And yeah, anecdotally, I can say it is a thing. It's just on a continuum. So it's one of those things. So I'll get through these last couple. And again, do apologize to anyone that we're not able to get to those questions. I see there's information that's been repeated in Niall's kindly, our moderator.
I will say this, James, anyone who knows me, pick up the phone, send me an email. I can talk about this stuff underwater. So just let me know if you've got any questions.
That's okay. Any research with AOD population clients who are also using, I'm not sure if it's prescribed or might be sort of having problematic issue with benzodiazepines and buprenorphine?
I don't know about that specifically. Like I said, there's not enough research in the alcohol and drug area. I know in New Zealand that there was a psychiatrist working in alcohol and drugs who was very interested in doing more work, I think, in that specific area. His name is Tom Flewitt. So that might have gone somewhere. But I don't know about that specifically. I would love to see some happen. I'd love to be part of it. If there's someone with interest in that, I'd like to see that we can get something like that up and running if there hasn't already been.
Cool. Question about training. Is there any prerequisites? I know you've described what's any qualification prerequisites needed, or
some sort of mental health qualification. Really is all they want. Counsellors can do this. GPs have done this. Some sort of training around that they will want to see, but no particular discipline is required.
Excellent. You will have seen, I hope, a lot of thank yous and appreciations as people have left.
Thank you.
And happily, I'm sure we'll send you the summary of all the comments.
Indeed.
Probably our last question, if that's okay. And again, I really sincerely apologise. We've just got to be mindful of time. EMDR for smoking cessation. Any resources, evidence, any guidance around that?
Yeah, a little bit is there. Once again, largely anecdotal kind of stuff and less actually hard research. But for anyone who's really interested in this, there's a man named Jim Knight, spelled Knipe, and he has written a book called the EMDR Toolkit. And in that, he actually describes an intervention that he uses targeting someone with an issue with smoking. And he actually does this really amazing process where he says, could you imagine something that you have absolutely no interest in, say eating Brussels sprouts, for example? Could you imagine if you felt like that about smoking? And he uses that as a bit of a sort of target range to get the desire to have a cigarette down to zero for this person. But again, we need hard research on this that really shows it. But people are interested in it, and there is work being done. Again, I would say if there's trauma in the background, the best evidence is let's treat the PTSD for that person first, see where that goes. Maybe then come back to maybe targeting the smoking for that person and taking it from there.
Good. Look, I think
I will answer one more that I saw because I just can't help myself.
Yeah.
People asked about doing it via video.
Yes.
Yes.
Yeah.
In the past 2 years, we've had to get really good at that. And yes, it can work really well via video, and there's pros and cons to this. So one of the things that I do when I do my video sessions is a thing called the butterfly hug, where you get someone to do this and tap their shoulders alternately. And we use that as the way of doing it. The difficult part is I can't directly control exactly what they're doing, but I can tell them to go slower, faster, that kind of stuff, and I can watch what's happening. That makes it slightly more tricky. The positive is the person can feel sometimes safer in their home environment to explore this stuff. And I think that distance from being in the therapy room can sometimes be a positive for them. So 100%, it's now used quite extensively in a video sense, and I use it a bit myself in that way.
Good pick up, because that is a very good important question.
It's contemporary. It's a contemporary issue.
yeah, the genie's out of the bottle on that one.
That's right.
Sure. Hey, look, thank you, Anthony. As always, a pleasure to hear from your practice wisdom and experience, and thank you for generously sharing that with the audience across the Inside APSAT community this morning from wherever you came. Thank you also for those who joined and who made comment and have thanked Anthony as well through their chat. So we look forward to seeing you in next Wednesday, and we'll say goodbye now so that everyone can get on with their day. Much appreciated.
Thank you, everyone. Thank you, James.